Okay, thank you everyone for coming today. I'm glad you chose this talk as opposed to the Red Hat Lady Marching Band. Don't know if you saw them. I helped two ladies find the East parking lot this morning. All right. So my talk is called Top Down and Bottoms Up, its approach to epilepsy. And we're going to talk about epilepsy and some movement disorders today because we'll see they're very closely integrated. So a top-down approach, so we're going to start with an allopathic perspective and talk about how they might approach a patient with epilepsy and movement disorders. So once we understand that, we can better understand how we can complement that treatment as our approach, which would be our bottoms up. I don't have any disclosures, no disclosures, only financial burden, no financial gain. I went to the American Academy of Neurology conference this May, which was very exciting. I loved it. It was my first time there. It was in Philadelphia, which is where I hope to practice one day. These are all the doctors' talks I went to and I will be referring to today, except for this last one. Dr. Fritinger is a fellow of neurology pediatrics at the Children's Hospital of Philadelphia, and she's just I would consider her a friend now. She's been very helpful in pursuing my future career, so I wanted to shout out to her. As I said, we'll start with the top-down approach, the allopathic approach, and then we'll move back into our realm of medicine. So what is epilepsy anyways? It can be genetic or acquired. So acquired would just be your TBI. Today we're going to be focusing on the genetic type of epilepsy, which is majority of epilepsy. And we know a couple things about that. I particularly put on the slide SLC2A1 mutation, which encodes for a GLUT1. And when that mutation is found in someone, they will not only have epilepsy, as I put in the slide, but that is the particular condition where we treat with our ketogenic diet. So I put that up there just so we can wrap our heads around that. There are known genetic causes in about 40% of children who are diagnosed by age 3. That's only 40%, which at the conference they made it seem as that if that was impressive, but I was like, what about the other 60? Where is that cause? So I think that could be definitely an area where we could look for a root cause. And if we remember, just to jog your memory, excessive glutamate is the proposed pathophysiology of epilepsy. Lastly, I wanted to add, I said we will be talking about epilepsy and some movement disorders. So epilepsy is closely linked to paroxysmal dyskinesias. And I put a link here, but we're going to watch a video later, but this also links to a separate video. Do they get the slides? Okay, great. You might be able to access that. If not, we can see the video later. And paroxysmal dyskinesia is abnormal episodic movement. So episodic, we think epilepsy is also episodic. So that's kind of where they integrate. And it can be associated with migraines and ataxia in addition to epilepsy. And the patients are conscious during these episodes. So it's just like movement and kind of like Tourette's. So first I'll start with the case presentation. So we have a 4-year-old male who comes to your clinic with episodes of vertigo and ataxia. There he is, the cutie pie. And now he is 8 years old and he presents with classic migraines. And then lastly, at 12 years old, he has an onset of hemiplegic migraine. So this is the story of his life. So he can come to you either at 4, 8, or 12, doesn't matter. You can each one of you can be one of those doctors. Hemiplegic migraine, just to remind you, it can be sporadic or familial, meaning genetic based. And it's basically a headache without aura and motor weakness all on one side, hence the hemiplegia. So are all these symptoms related? That's being the great naturopaths that we are, we ask ourselves this question. And to answer that, I'm going to dive into a couple of genetic terms and a specific genetic mutation we'll talk about. So synaptopathies, transportopathies, and channelopathies. These are all different areas of a neuron that can go wrong in our brain and cause epilepsy. So first, synaptopathies is an issue with the release of proteins from the presynaptic terminal. So as you can see in the middle there, if I can get that's our synaptopathies. So it's where the vesicle binds to the presynaptic terminal. So there's an issue probably with that binding, the vesicle fusion. Transportopathies, that's kind of like the ketogenic diet one, where our GLUT1 can't transport into the blood-brain barrier. and channelopathies is more so an issue with the ion channels responding to voltage, changes in voltage. Does that make sense? Feel free to ask me any questions as we go. So with all of that basic science in mind, we're specifically going to talk about the PRRT2 mutation today, and that is right here. And it is a synaptopathy, as you can see by the image. And we don't know too much about it, but we are learning, and what we do know is that it is an autosomal dominant condition. The homozygous mutation presents more severely with more severe symptoms as opposed to heterozygous, which makes sense. Typically, it's a frame shift mutation, and it's expressed at the brain and spinal cord level, in particular the cerebellum and the hippocampus, and I can't remember the other one, but those two mainly. The function is typically inside the cell, presynaptically, specifically in a glutamatergic cell. Again, that makes sense because epilepsy is associated with excessive glutamate. And the main mechanism is that synaptopathy. So specifically, we'll go into this on the next slide, but that vesicle fusion, there's an issue with calcium sensing, telling the calcium, or telling the vesicle to fuse is initiated by calcium. And even more specific is the SNAP25 protein, which we will get into. Here it is. So what's the issue? Exactly what is SNAP25? So this is your basic Khan Academy drawing of a axon terminal. Just to jog our memories, that's what an axon terminal looks like. And zooming in onto our presynaptic membrane is in the yellow. And up top we have something called snare proteins, and snare proteins are what help bind this vesicle that's filled with neurotransmitters. Just imagine all the dots in there. They're filled with neurotransmitters. That's going to fuse with our presynaptic terminal and exocytose. Yeah, that's right. Exocytose all of the neurotransmitters into our synaptic cleft, which is our in-between. So specifically the snare proteins include SNAP25, and SNAP25 is part of that binding. And our PRRT2 mutation has been associated with SNAP25. However, like I said, the research isn't quite clear whether it's specifically just our SNAP25 or more and more research is linking more so to the calcium sensing. So as we can see in the next image, calcium sensing is the issue. And calcium initiates this protein called synaptotagmin to grab the vesicle and bind it to create a pore in the presynaptic terminal. So there's a couple areas where things could go wrong here. And it's just a fun aside, this is exactly how botulinum toxin works. It inhibits this binding process. I believe it's SNAP25 in particular. And again, just to reiterate, it is a calcium issue with the PRRT2 mutation that we are seeing. Anyone have any questions so far? So back to our case. We've got our 12-year-old boy is with us. He's got hemiplegic migraine and this history of classic migraines, vertigo, and ataxia. What do you think he has? Oh, a PRRT2 mutation. Everything we just learned did not go to waste. So there he is, smiling and happy because we found that he has a PRRT2 mutation. And what does that mean? It means all of his symptoms are explained. All three of those things I discussed are typically seen with this type of mutation. And at age 19, we were then able to prescribe him carbamazepine, which is an anti-epileptic. And we believe this works because when PRRT2 mutations are found, there's an increase in glutamate, and thus carbamazepine decreases glutamate. So I listed a couple triggers there that you might see with a PRRT2 mutation, and a description of the time an attack might be present. And specifically, when they've looked at studies with knockout mice, the progression that they see as mice age is a decrease in neuronal migration in synapse development. So they propose that that's what this gene is important for. But again, that's in mice, so take that for what it is. After all of this, the mom of this 19-year-old male remembered that when he was an infant, he was treated with something similar to carbamazepine. She wasn't quite sure. And that's kind of where I was like, wait a second. What if we just took a better history and understood that better and did a better job looking into files and whatnot, old EHR databases. So something to consider where as we as naturopaths have a longer time with patients, and we could negate the entire stress of having this hemiplegic migraines and whatnot. So as I said, here is our video. It should work. Okay, so it's a 1-minute video. The sound we don't need because it's in Swedish. So this is a 28-year-old male who suffers from paroxysmal dyskinesias, so similar to our patient. And as you can see, it's exercise induced for him. So as he started walking, he experienced all the tics and twitches, and he's still conscious. He can't control that. There he goes, and then it will end shortly. And I believe it started when he was 10 or 12, and he's now 28, but they were able to find this PRRT2 mutation in him and treat him with carbamazepine. So this is after. So after he has taken this medication, again, he will run for us. So nothing with walking, which is awesome. And last time he ran, he had trouble, fell to the floor, nothing. He can even walk backwards. So I thought that was a pretty interesting video. As I mentioned, we do not know the exact mechanism. The research is hot and heavy. And what we do know, and what the big conclusion of the session that I attended at the American Academy of Neurology conference was that they're starting to realize now that there's many genes that can represent one single phenotype. And when I say phenotype, I just mean all the different symptoms that someone presents with. So like that headache, hemiplegia, migraines, ataxia, vertigo, all of that. So many genes can represent that, or one gene can represent many different phenotypes, many different symptoms. So they're realizing that their system maybe isn't working so well. So I think this is where naturopaths can really come and be supportive in this case. There's an overlap in genes. Are these diagnoses really that different, is what they're beginning to question. They're starting to look more into epigenetics. And interestingly, the PRRT2 mutation results in epilepsy in infancy, but as it progresses into childhood and adolescence, it becomes these paroxysmal dyskinesias. So that's exactly what our patient had when he was a kiddo, or an infant, I mean. He had that epilepsy and was treated with carbamazepine. And now, as a child and adolescence, even into teenage years, he was suffering from paroxysmal dyskinesia-like symptoms. So interesting, and that's all genetic-based. So is it as accurate as we previously thought? And us as naturopaths can look at the whole person and really understand that it's a person in front of us, not just a genetic mutation. And this is, just to reiterate, here's an example of how an allopathic physician might approach someone with epilepsy. And they have this really cool thing. Someone denoted it as Tinder for genes. And basically, if you have a genetic mutation that you think might be causing it, you can go on this site and see if there's another doctor in the world that is having that same genetic, has a patient with that same genetic mutation, and see if there's correlation. Yeah, pretty cool. So, as I said, this is a great opportunity for us to step in. We've been sitting here waiting this whole time. Here we are. I know, I tried to just find a wild, crazy herbalist. I found the scary one instead. I think we look more something like this, I would say. Eat your vegetables, get your exercise, keep moving or you'll die. It's Dr. Walton there. Okay. In addition to these hardcore science-y talks I went to, I also found an epileptologist, Dr. Marie Collier of Colorado, who did the AIHM fellowship, which is a 2-year fellowship for MDs and DOs. And one of the sites that they shadow at is our school, and I think OCOM and a couple others in San Diego, and I don't remember where else exactly, but so they basically learn our medicine in a 2-year fellowship. And so what she talked about, I'm just going to provide some fun facts. 30% of epileptic patients do not respond to medications. Again, great area for us to step in. AEDs, that's anti-epileptic drugs, block vitamin D absorption and do affect bone loss. So definitely with our young kiddos who are on AEDs, let's get them some vitamin D and support their bones, support movement, weight-bearing exercises to an extent, of course. They're young. 60% of epileptic patients also suffer from depression. We've got a ton of things for depression, right? Chamomile tea, Bach flower remedies, lovely.
By supplementing vitamin D, would it still impair their absorption? Or is that specifically through skin, the dermis, synthesizing vitamin D from the light?
I think it would just kind of negate it. There'd still be a malabsorption, I believe. I'm not sure exactly. Yeah, I think supplementing would be beneficial just to prevent that, because as you're growing, you want that bone growth, right? So, did that answer your question? Kind of, sort of. Answer is I don't really know. And I don't think other people do either. So she also mentioned this fun fact, which kind of leads into our next talk I'm excited about. It involves energy. So the EEG, so that's what we measure epileptic seizures with. We can do sleep studies with it. It's all the cords that attach to your brain. So that was founded by a man named Hans Berger. Hans is up here on the left corner, and I don't know if this is him on the upper right, but I just thought it was a funny picture, so I added it, and it comes up when you Google his name. So Hans discovered this when he joined the cavalry. He was almost trampled by a horse. There he is on the bottom left. That's a bull, but we get our point. And in this moment when he was almost stomped on and stampeded, he had a moment where he thought of his sister and his family. And at that exact same time, his sister wrote him a telegram from home, so miles and miles away. And that just got him thinking about telepathy and how does this all work? And so then he was able to invent the EEG based on that, which I thought was really fascinating. And got me thinking. I took Dr. Kalman's course on integrative phytotherapeutics. Got me thinking about Dr. Kalman's, Rudolf Steiner, and I was like, his astral bodies were talking to the world. I don't know if anyone else knows that. Okay. And last but not least, I have two examples of epilepsy and our medicine and how they combine. So the microbiome in particular. I was interested in this at the conference. Unfortunately, there was zero talks on the microbiome at all. No one really knew much about it. So I'm hoping that I can go and change that and maybe get some research in. Right now, in terms of epilepsy, there is a FMT, that's fecal microbiota transplant study on 50 participants, not particularly kids, age 6 to 70, underway, and it should be done by September 2019, and that's in China. And another interesting case study is on a 9-year-old male with Tourette's syndrome. So Tourette's is similar because it's episodic, you have tics, similar to epilepsy and paroxysmal dyskinesia, so that's how I correlated it with epilepsy. So they're treating this 9-year-old male who initially came in, and he had tried some herbal protocols. Again, he is in Beijing, so China. He's tried some herbal protocols. Those didn't seem to be working to control his tics, or Tourette's rather. And so then Doc put him on Tiopride, which is a dopamine D2 receptor antagonist, and some probiotics. They worked for a little bit, a couple months, and then stopped working. After they stopped working, they decided they were going to try FMT. And as you can see here, the Yale Global Tic Severity Scale is what they used to judge his improvement. And he went from a total of 31 on that severity scale, so pretty bad, to 5. And you can see his motor and vocal tics also decreased. His parents noticed a huge difference. The images here are him pre and post. He's happy, smiling, getting some earthing, playing in the sand. And that is everything for those of you listening. I do have some information on neuroimaging for the generalist. Yeah.
Did they talk about cannabis at all?
No. So, yeah, that's interesting. I think a lot of doctors at the conference weren't really pro-cannabis, which makes sense. And I didn't bring it up too much, but I got a vibe that it was person non grata. Yeah, I wish I did. And I think they had a whole live well section, so that's where I saw the one doctor who did the 2-year fellowship with our school, and I think she might be more interested in that, but you know, it's a small field still, unfortunately, or small-minded. Anyways, so for those of you listening at home, if you're interested in obtaining a handout, if that's okay with Christine, I don't know, I can email you this handout. Great. Awesome.
Can you explain the images?
Yeah, I can. Great. This is another case I have here that was presented. This is a different session, kind of completely different. I just thought this would be practical for primary care physicians. So a 31-year-old male came into the emergency department. He was confused. He couldn't remember things from the past 2 months, and he could remember the five words that were said to him immediately, but 5 minutes later could not remember. So he was indicated to get some brain imaging done, and initially they didn't see anything. So on the left where it's normal, his T1 and T2 and DTI, they did those 3 above the red line, and those were all normal looking. So of course they sent him home because they didn't know what was going on. About a week later, he came back. He was much worse. Now couldn't remember 6 months prior to being in the hospital. Last time it was just 2 months, but now it's 6. And so they did more brain imaging thinking they might have missed something, and they did. So he ended up being diagnosed with GAD encephalitis, which is basically just an autoimmune encephalitis. GAD is the antibody. And so does this mouse work? Okay. So I'm not an expert at this by any means, but the sheet kind of helps explain it as well when you're looking and trying to determine the difference between T1 and T2. And it's basically just a difference of hypointensity and hyperintensity, so black, white, and gray imaging, and there we are. So it's really easy to see on the T2 that this area right here is different from this. It's much, much whiter, and again, it's hard to see, and I'm not the best to particularly point out exactly where it is. And then again, right here, you see there's a little bit of a darker pigmentation. And I'm not gonna go over the bottom 2 just yet. And here it's even more clear. You can see that this area and this area are hypopigmented, or hypointense, sorry. Nope, hyperintense, they're whiter, and that is the area of encephalitis. See some fluid around as well. So that was an interesting case. And then the ADC and GRE is explained on this sheet. So, or it's on the slides as well. All right, so that is everything. Those are my resources from this chart. And that's all. Thank you so much. Thanks, guys. Great, I did only take